He's a pediatric He's a pediatric orthopedic surgeon at Evelina London Children's Hospital, which is a part of Guy's and St. Thomas NHS Trust Hospital. His main focus of practice is treating the children with neuromuscular problems that include cerebral palsy, spina bifida, and many other neuromuscular conditions. He's an associate editor of McKeith Press, which brings out the very famous and very popular journal that's a developmental medicine and child neurology. And the topic of the today's discussion or the interaction is basically the new definition or the description of cerebral palsy, which is published only a few months back. And Dr. Martin has played a key role in the process of updating this definition. Along with Dr. Martin, we have two other experts. The first is Professor Benjamin Joseph. Professor Benjamin Joseph is Professor Emeritus at Kasturba Medical College, Manipal. And he, along with Dr. Jory, played an instrumental role in developing the pediatric orthopedic as a subspecialty in India. In addition to that, we have Professor Freeman Miller, again, a very good friend of Indian Academy of Cerebral Palsy. To tell you about Freeman Miller is probably not right thing, but just what I understand him is like his few books on cerebral palsy, I consider as Gita or Bible or Quran in cerebral palsy. And the second edition of his book that includes everything, all the aspects of cerebral palsy. So with that short introduction of our experts, now I request Professor Dr. Martin to share his views on the current updation on the description of cerebral palsy. Over to you, Martin.
Okay, thank you.
Yes, your screen is visible.
Excellent. Well, thank you very much for that really kind introduction and for your invitation to participate in this webinar, which is a real pleasure and an honor. Thank you. I don't have any disclosures other than that, as you mentioned, I'm an associate editor in McKeith Press. So this presentation is aimed at discussing the recent proposed updated description of cerebral palsy, which was published online in April and in hard copy in the June edition of Developmental Medicine and Child Neurology. The authors are Professor Bernard Dan, pediatric neurologist, Professor Peter Rosenbaum, developmental pediatrician, Dr. Lucinda Carr, pediatric neurologist, Mr. John Coughlin and Ms. Nanyelem Noeke, who are parents of persons with cerebral palsy and members of the International Cerebral Palsy Society, and me. And I was invited to join because of my interest in this area. So my presentation will inevitably be influenced by my own perspective. So for a complete picture of, it was a team of everyone's perspectives, I'd encourage you to read the paper. So Dhiren suggested in his email that I cover some questions, including why do we make the change? How did we work to prepare the new definition? And what were the areas of controversy? I'd like to cover also a question about what has changed. So the proposed updated description could really be said to have its roots in a meeting of the International Workshop on Definition and Classification of Cerebral Palsy a little over 25 years ago, or 20 years ago, sorry. And it was agreed at that meeting that cerebral palsy was not an etiologic diagnosis, but a clinical descriptive term. The work of this group progressed, and in 2007, the group published their definition and classification of cerebral palsy, which was a short definition followed by a detailed and extensive set of annotations. Of note, two of the authors in the present updated description, Professor Rosenbaum, Professor Dan, were authors of the original definition also. So this is the original definition. It's very concise, it's very good, consisting of 2 sentences, and as noted, with extensive detailed annotations. And of interest reading it, the initial, although it was listed as a definition, it's explicit that it's a description, which is less fixed and more flexible. You could think of the difference between describing a person and defining a person. Cerebral palsy was said to describe a group of permanent disorders of the development of movement and posture. And this is a pragmatic approach, because defining cerebral palsy as an entity, a group of disorders, gives it a somewhat independent status, which facilitates discussion. Sorry, I've jumped on one. These disorders were attributed to non-progressive disturbances in the developing fetal or infant brain. And as we've seen, the term permanent in the first line and non-progressive subsequently caused a degree of discussion, which led to the new classification. In the annotations, it was noted that the cerebral palsy was, again, a clinical formulation, but also a term which described an important and identifiable group of persons, so that it both described a group of disorders and a group of persons with those conditions, which suggests some perhaps areas of ambiguity in the understanding in the initial discussion. The 2007 definition was very widely accepted and has been extensively cited. But over the last few years, Professor Rosenbaum and Professor Dan were approached by a number of people about a possible update to the definition. And the perceived need for an update was related to changes in our understanding of cerebral palsy, the etiology, an increasing awareness of global issues, and the importance of adults with cerebral palsy, and on changes in language and concepts surrounding disability, and a focus on health and participation. So this sentence from the current paper, the proposed updated description, I think summarizes the approach or the ethos of the team involved. So cerebral palsy is seen as an evolving conceptual framework rather than a static and fixed entity, and something which can evolve as our understanding evolves. And really the emphasis of the group is very much on evolution rather than revolution. The idea of keeping all that works about the previous definition, but seeing whether there are developments that can be made that can be more helpful. Okay? So the first step was to list all of the people who would need to be involved in discussion or who would be interested in being involved. And these range from persons with cerebral palsy, with their family members and caregivers, right through clinicians to CP registry, researchers, organizations funding research, and academic societies. And following this stakeholder analysis, the next step then was to have an online focus group discussion with people with cerebral palsy and their families. So we discussed with members of the International Cerebral Palsy Society. This discussion was held in 2022, and it came out with a few. One of the aims of this discussion was to see whether the term cerebral palsy itself should be retained, or whether a newer term should be substituted or developed. The persons with cerebral palsy and their family members felt that the term had a number of positive aspects, including self-identification of persons with cerebral palsy within a support community, and access to healthcare and societal benefits, which may not be available without that diagnosis. There was also, however, a suggestion that the term cerebral palsy, which was taken by some people to mean a paralysis or weakness of the brain, was felt to perhaps focus on brain impairment primarily, and in this way may misrepresent abilities and potential of people with cerebral palsy. But overall, the persons with cerebral palsy and their families that joined the discussion were very strongly supportive for retention of the term cerebral palsy. Okay. So following this, we sent out an email survey in April 2023, about 2 years ago. And this survey asked a number of questions. So what aspects of the 2007 definition should be retained? Whether any aspects should be removed? Whether any needed to be changed? Whether there were components that were missing from the earlier definition that could be included? And who benefited from a change in description and who may be harmed? So again, here, the focus wasn't so much as saying we are going to make a change, as asking people, how well does this description work for you? Is there things that could be done to it that would be of benefit? Okay. We got some very good responses. In general, there was support for updating the definition while retaining the core of the 2007 definition. Most respondents were very keen that we describe cerebral palsy as a lifetime neurodevelopmental disorder, and in this way explicitly including adults as well as children. There was very strong feeling that we should include persons with cerebral palsy and their families in the discussion, so that this wasn't a discussion made by clinicians in isolation without having families involved. A number of respondents expressed difficulties with the term non-progressive disorder and permanent disorder. As they said, it was difficult then to explain to families how the manifestations of cerebral palsy could change. And there are quite divergent views on whether or not the definition should include a minimum age for diagnosis and an upper limit. With essentially, there were a number of people who there wasn't clear agreement within the disagreement, if that makes sense. There were a number of different opinions involved, which were often not entirely in accordance with each other, suggesting that this may be an area of ambiguity. There we go. Sorry, I jumped forward too much. Yeah. Following this, we had an in-person and online meeting at the EACD meeting in Ljubljana in May 2023. And following this meeting, we put together a first draft of an updated description of cerebral palsy, which was then circulated with comment. Following the comments received, it was modified again and presented by Bernard Dan at the American Academy for Cerebral Palsy and Developmental Medicine meeting last year. Received a lot of discussion and comments and was revised further before being published online in April and in hard copy in June with an invitation for responses. And the most recent discussion was an in-person discussion at the combined EACD-IAACP meeting in June last month. So we talked earlier about the difference between a definition and a description, and that's something we can discuss further. So the proposed update is really a description of what cerebral palsy is, rather than an extensive operational definition, which would allow precise classification and facilitate diagnosis. The description includes a clinical description where the terminology is quite defined and tight, and a more accessible proposed plain language definition for accessibility. Okay. So just to remind you, here is the 2007 definition. And then we can move on to the proposed update. So we can go through it briefly. You can see it longer. We've moved from 2 sentences to 4 sentences, and we've increased the word count, hopefully validly. So the term cerebral palsy and the acronym CP have been retained, both because that's what people wanted and also to protect people who may be damaged by alteration in the term in terms of access to care or funding. Instead of a group of disorders of movement or posture, the phrase used is an early onset, lifelong neurodevelopmental condition. Early onset implying that it's not early, but lifelong, specifically bringing in adults with the condition so that we see it through the lifespan. Neurodevelopmental is included because in the ICD-11, cerebral palsy is not listed as a neurodevelopmental condition. And certainly in some way, some discussion from the cerebral palsy group in France that cerebral palsy is not considered there as neurodevelopmental. And we use the term condition rather than disorder, as a condition emphasizes a way of being and a person-centered approach, as opposed a condition is something somebody has, or it's how they live, rather than being a separate and independent disorder. We included limitations in activity early on. That was a specific representation to the activity dimension of the ICF, and the focus on motor disorders. And following recommendations, we included different presentations of cerebral palsy because these are the presentations most widely used in CP registries. So then this description would fit more easily. We put in a slightly unwieldy sentence, I'd admit, about to try to explain how, although cerebral palsy was not a neurodegenerative process, it can have changing manifestations with age. And we brought in a new sentence that the phenotype of cerebral palsy is complex and heterogeneous, with each person experiencing a unique presentation, to really emphasize the individuality and uniqueness of each person with cerebral palsy. Finally, primary and secondary impairments were mentioned and discussed in more detail, and the difference was discussed in the annotation, and we can discuss that later, and the effect on participation in life. We also included a plain language description. This was written predominantly by John Coughlin and Nanye Weckham, with support from Bernard Dan. It wasn't intended to be a literal translation of the clinical description because it's written by persons with lived experience of cerebral palsy or lived experience of a family member of cerebral palsy. It's going to contain a different perspective, and we were comfortable with that. So the first sentence describes the experienced persons living with cerebral palsy. Next one discusses something about the cause of cerebral palsy. Interestingly, the persons with cerebral palsy and their family members weren't very keen on the attribution of cerebral palsy to injury to the developing brain. They wanted to be specific about the part of the brain, with the implication that the other parts of the brain weren't involved. They talked about the overall uniqueness again of cerebral palsy and some aspirations for management. So the online paper from April invited responses, and the published paper invited responses. And as noted, we had an in-person meeting in EACD. So I thought it'd be useful to go over the areas of agreement and disagreement. There was really wide agreement that cerebral palsy was a valuable clinical construct which should be maintained. There was agreement that cerebral palsy should remain a clinical formulation with diagnosis made on a clinical basis, that the description should emphasize the lived experience of persons with cerebral palsy and should focus on their function and participation, and on recognizing cerebral palsy as a lifelong condition. And also strong encouragement that whatever description we come up with or what ends, that description would remain relevant across all resource settings. So it would suit high-income countries, middle-income countries, and low-income countries equally well. We had areas of disagreement. There was no agreement on whether it should be a description or a very precise or more precise definition. There was no agreement on whether the description should add procedures for the diagnosis and management of cerebral palsy, or whether an upper age limit should be included. There was disagreement about whether or not the different clinical subtypes of cerebral palsy should be included. Discussion about the language used and the balance between precision and accessibility and inclusion. About the terminology and the plain language description, and about differences between the clinical and plain language description. So some of these are in more recently and will be applied to the next revision, but in general, where there was agreement within the disagreement, where there was a large proportion of the people disagreeing were saying the same thing, then it made sense to change. But for some aspects, there was a lack of agreement. So some people were very definite that there should be an upper age limit. Some people wanted a specific age limit, which other people didn't. They wanted a different one. Some people wanted the terminology used to be more precise, and some people wanted to be more accessible, with some people saying we should write the whole clinical definition in accessible language. So it's really interesting, and it's more to say that rather than having specific disagreements that were ignored, we try to take in everything that fitted together, but allow that there's always going to be some areas of ambiguity. So as I said, overall, responses were really constructive. They identified areas of ambiguity and disagreement, which is probably part of any clinical concept and which would benefit from further exploration. There was very strong agreement and support for inclusion of a plain language description and involvement of persons with cerebral palsy or lived experience as parents, a perhaps discussion about the terminology used, and a positive response to the proposed update. So this is not a completed document, it's a proposed update, and it's a process and evolution. The next steps will be revision of the draft update of the definition for publication, along with all of the correspondence we've received, so that people can read the proposed update along with all of the responses that we've got, both in support and to disagree. Once we come towards an agreed update, we need to think about consideration of translation into other languages in a way that is sensitive and maintains the concepts involved, and perhaps consideration of context-based operation definitions deriving from the description, which can facilitate more precise diagnosis or classification. So that was a relative gallop, and I think I'm still in time, of the definition. As I said, it's presented more clearly in the paper, so I'd encourage you to read that. And thank you all very much for listening.
Yeah. Thank you, Martin, for telling us about the whole process, how it went. And that's really very interesting. Now, before we start our interaction, I request Professor Benjamin Joseph to share his views. And yes, sir, you can share your screen. Yeah. Yes, we are able to see it.
Okay. We listened to this very erudite discussion and description of cerebral palsy from Martin. I'm just going to make a few comments. First of all, in the 2007 version, it was put as a definition, whereas now it's called a description. So I get the impression that, which you confirm, that this is not a definitive statement, that it is evolving, and you might have something more to add or change in future. One of the most important things message that I got, which I think we need to convey to the physicians, surgeons, and even the patients, is that this is not degenerative, the condition, although the manifestations may change with age. And we need to look at some of these manifestations that change with age. One example is, here is a young boy with severe crouch due to cerebral palsy. And it's very obvious that when the crouch started, it was pretty mild, maybe a few degrees of knee flexion deformity. And because of lack of treatment, it progressed to this extent. We need to emphasize that the increase in the severity of the deformity must not be interpreted as progression of the underlying condition. It was very clear that when you see the child walking, this pattern of walking was much better at the onset of the crouch but it progressively deteriorated. Some more issues of changing manifestation with age. I think it's important that we acknowledge that achieving milestones is due to neural maturation, and that shouldn't be interpreted as an improvement in cerebral palsy. The reason why I'm emphasizing that is we need to be aware, I mean, all of us are probably sitting and listening to this are aware that the three phases of neural development in the human being is the first part is in the early intrauterine life where the parts of the brain are formed. The second is also intrauterine where connections between each of these organs are formed. But what happens postnatally for quite some time is the myelination process. And it is as this progresses that milestones are achieved. Now, I think it is unfair to intervene at some point and claim success in improving the status of cerebral palsy when all that you might be seeing is the normal myelination process going on. So I think we need to be careful about this because the improvement in CP, the true improvement in CP doesn't occur. What we're trying to do is minimize the problems, the consequences of the neurological impairment. The next statement, which I think is important, which has been emphasized, is that cerebral palsy is a permanent condition starting very early in life and not a transient one. And I like the statement which says the children who received a diagnosis of CP but has outgrown it never had CP. Fantastic. And that's something we need to emphasize. The second part of the description, which I put in 2 slides just for the lack of space, is important because in addition to dysfunction, people with CP frequently encounter primary and secondary impairments. This needs to be emphasized, particularly in our country, where we saw an interesting phenomenon some years ago. We looked at a cohort of 100 children with cerebral palsy, and we noticed that 82% had one or more associated issues which are listed. 54% had more than one associated disability. And the sad part of it is that though 43% of these children were referred by a primary care physician, one or more of the disabilities had not been recognized. And the only disability that had been treated was epilepsy because it was so obvious. And this is why some years ago I emphasized that very often we are the first point of contact as orthopedic surgeons. I'm speaking from the point of view of an orthopedic surgeon. And the reason is this, that virtually every parent that I have encountered over 30, 40 years comes and tells me my child is not walking. They didn't tell me that the child can't see or the child can't communicate. They told me my child is not walking. Can you make the child walk? Will he or she walk? Their emphasis is on locomotion. And therefore we tend to forget there's so much more that the child needs to do. Communicate, have a good vision. Mobility next. But walking itself is probably not that important compared to the other important things. And we suggest that whichever specialties, if they come primarily to a pediatrician or to a neurologist or to an orthopedic surgeon, it's incumbent on us to examine the child in toto and to examine these associated problems as well. Look at the vision. 54% of the children we studied had visual disturbances. And we picked up refractory errors as high as 15 diopters, which had gone undiagnosed till we saw the child. And you can imagine in a simple classroom, the teacher writes something on the board and asks the child to read it. The child doesn't. Not because the child doesn't know or understand, but the child can't see the board. And what is the assumption? This child's intellect is poor, cognitive abilities are poor. In short, you can use the rude term, this child is retarded. Of course the child is not retarded. The child can't see. And so it is incumbent on us to remember this aspect, which has been emphasized quite well in the description. I have a few concerns about the description. One is, this has been stated that you need a balance between clinical precision and accessible inclusive language. I wonder why we are so concerned or sensitive about using terminology like disorder and disability. Why do people think that it is stigmatizing? Because I don't think that if I use a word, English is not my mother tongue. And what I have learned is I call this a disorder. And I think that the child can't walk well, so I think he's got a locomotor disability. I'm not trying to stigmatize him. I'm trying to use language as best as I can. Why are people so sensitive about this and create an issue? That worries me, because that impedes a simple understanding of the condition. The last issue that I'm worried about is, in the plain language description, it ends with the right resources, therapies, and support from family, people with cerebral palsy can thrive and live fulfilling lives. If you were to put this up, and if you assume that all my parents, the parents of the children that we treat, understand English, we'd be in trouble. Because the parents hold on to the little hope that we can give them. They go from pillar to post, from one specialist to another specialist. Will my child walk? Will my child turn around in bed on his own? Imagine that you've got a child, not a mild hemiplegic, but a quadriplegic child, GMFCS 5, subluxating hips, scoliosis, bad upper GI function, seizure disorder which is not controlled. And if you tell the parents that with the right resources, therapies, and support from family, people with cerebral palsy can thrive, they can assume that they're not getting the right resources or the right therapy. And they may hang on to this description and hold us responsible. So I think we should be a little cautious about that. These are the only comments that I have to make. They're not criticism, but things that I honestly feel should be addressed. Thank you very much for your time.
Yeah. Thank you, sir, for your word of wisdom and the word of caution. And I fully agree with you that when we say that the hope and optimism are very important qualities of the life, but when we put something on paper, and if the child with a GMFCS 4 or 5, they don't expect walking or they don't get walking, then they would probably consider that it's a failure of the treatment. So that's a very important point. So now let's
one last comment.
Yeah.
Please remember that this is the background we come from. 80% of our people are from rural India. We have to adapt to treat them. So please remember that don't extrapolate data, suggestions from the West alone. Please think about the background where our children come. Thank you.
Yeah. Thank you, sir. Thank you. So that's a very important point. Martin, would you like to say something on this before we move on to the more questions and interaction?
Yes, of course. Thank you very much. Thanks, Professor Benjamin. With regard to the first comment, what the paper reported was the responses that we received. And I appreciate your response is very specific, but there is disagreement in the responses received. And if we're writing a description, then we try to be open to all of the responses, rather than decide from the start which responses we'll let through and which we'll block because we don't agree. In regards to the sentence about thriving and fulfillment, I'm not sure that the people who wrote that, who were the parents of adults with cerebral palsy, I'm not sure they were equating thriving with walking. And I think in a family setting, if you're comfortable and if you're nourished well enough, then you can be said to thrive. I don't think it's all about movement. Lastly, I agree completely that we have to be very cautious about how the description is interpreted and about different settings. And that's the reason for all of this process, but it's also the reason why this is not an operational definition. It's not telling people how they should define and classify cerebral palsy, because that may well be influenced by different settings, exactly as you've said. So, but thank you for your comments.
Yeah, so that's very important about the whole process. Now let's, Dr. Martin, I have a few questions about the process and now how we are going to go ahead. So do you think that there will be some resistance in the pathway of taking this description further?
I don't know. I think that's a really good question. So far, there's been support. There's been some areas of disagreement, like I said, where we've amended it and revised it, and that's been approved. Potentially, if now that we're explicitly including adults with cerebral palsy in the definition, that may have implications for healthcare systems which look after adults. I know our healthcare system currently doesn't do really well managing adults through transition and into adulthood, so it may well cause more issues there. But I think what we'd hope is that if there are disagreements, that if we can understand the reasons for the disagreements and work with the people who disagree, then we can develop a more inclusive description.
And like how open you are to the suggestions. So the definition has been now published in June 2025. So will there be any addendum to this, or it would be after 10, 15 years?
So the reason for it's kind of described in the paper. The reason for publishing it wasn't to kind of formally establish it as a description, but instead to make it accessible so that people could read it and comment. And the plan is to get all of the comments back, to revise it, and then publish it in a special edition where we include the updated description, the annotations, and the correspondence that has been received, so that the people reading it get an idea of the context in which it developed and about the different opinions on it.
Okay, good. So now, if I consider your team as a developer of this description, how would you like to suggest, or like the clinician to contribute for the propagation of this idea?
I think we've had a lot of input from clinicians already, which is essential. And I think, again, when the revised edition comes out, what we did with the previous on the paper was an email address and a web address where people could comment, and we invited people to write in letters to the editor or commentary pieces, which suggested links of commentary and references. And we received some really good stuff. So I think when that invitation comes up again, the more people who participate, the more representative any description will be.
Okay, good. So now we have one change, and that change has to be used in clinical practice. So now let us understand that how this change is going to affect our clinical practice. So I would like to ask Professor Benjamin Joseph, how will this new description will change the way clinicians diagnose cerebral palsy in early childhood? So will you expect any change in the process which we do for diagnosis?
I don't anticipate any dramatic change, because if I look at my practice in 2007 and my practice in a few years later, it may not have changed dramatically. But I think it is basically to be more reliable in making an accurate diagnosis. And that is going to be important for particularly children whom you're not entirely sure whether this is cerebral palsy or not cerebral palsy, because you do come across something like that. And if you don't have the luxury of having expert pediatric neurologists at hand, you've got to do this. And therefore, yes, it will probably help us. But I don't know whether it'll make a dramatic difference in our practice as it stands.
Okay. To Professor Freeman Miller, for any new tool, when it comes, we always look at like, will it help us in earlier diagnosis or help us to make the diagnosis more accurately? So how do you think this description will help us for those two perspectives, making it early diagnosis or more accurately?
Yeah, I think for the early diagnosis, it's going to be, I think the comment that Dr. Joseph mentioned about the fact people who said they outgrew their cerebral palsy means they never had it is a very good point. And so I am not sure this will be very helpful for necessarily the early diagnosis, but I do think, I suppose, it will be to identify those children who are at risk because it discusses brain injury or so. One of my concerns with it in the current description is I think it's good to have it defined as a condition. And in the paper, they mention that it is not an etiologic diagnosis. I personally would very much like to see this more clarified up front, because this, I think, is one of the biggest problems, especially with the increase in so many genetic diagnoses, identifying very minor genetic malformations, which are likely the cause of the disability at some level, but are static, non-progressive, and in every other way, and certainly 10 years ago would have clearly fallen into the definition of cerebral palsy. So I think the problem in the definition that it does not say that really cerebral palsy is a phenotype diagnosis, not an etiologic diagnosis, is, I think, a deficit in the description and is something that will continue to confuse people. And it's especially true, and I've seen this so much in my practice, where they go to see a neurologist or a geneticist, and the geneticist makes a diagnosis based on genetic findings of something that is relatively, it's a stable condition as best we know. And then the parents say, no, now I don't have cerebral palsy, I have something else.
Okay. Related to this point, I have two questions. The first question is to Dr. Martin, like how much it is required to have a MRI proved diagnosis? Do you think that 100% of the cases of cerebral palsy will have some or the other changes in MRI?
So I think in the description that I have to be aware of my limitations here. I'm not a pediatric neurologist. And I for aspects like these, I trust in the expertise of my pediatric neurology colleagues. But I think the group were very keen that, as Freeman had said, we make this a clinical diagnosis and a clinical formulation, realizing that access to neuroimaging is likely to be limited to specific health contexts. And this would reduce the applicability of the description. From the description, there is likely to be a more context-specific operational definition. So it means that the operational definition, how you precisely define cerebral palsy, how early you define it, what you need to do, may well need to differ depending on the resources that are available. But that's going to be a separate discussion with the people in individual contexts. We agree completely that I think if we get the description right, then the description could, in theory, apply to young people and adults with cerebral palsy, wherever they are. But the way of managing them and diagnosing them is going to be specific to particular contexts. Does that make sense?
Okay, and the second point is what Freeman said is about the genetic testing. Now, genetic testing has, like MRI, has become almost available to many of the patients. And again, the cost is going down significantly day by day. So how you expect this to be also included in the future description, not the current one, but the future description?
I'm not sure. I think it's going to depend on how we had some very strong views about including comments on genetic diagnosis and equally strong views about excluding comments on genetic diagnosis in the responses. So I think it's got, as you said, we've left it open for the moment, and it's going to depend on further responses, feedback, and discussion.
Okay. So we discussed about the diagnosis part. Now let's go to the next part, which is very important for all of us, is to plan the treatment. So the question to Professor Benjamin Joseph, do you expect any change in the planning? Let's say that help in the planning of the treatment by this description? Yeah, please unmute yourself, sir.
Sorry. Yeah. In the current form, I don't think that it can make too much change. But when it gets modified and more definitive etiological diagnoses are put in, then I think it might make a change. So as it stands, the answer is probably not dramatic.
Okay, so like if we look at the change in our practice for the diagnosis, whether it will be able to make diagnosis earlier or more accurately, and when it comes to planning, probably this new or the change is not going to make much difference to the clinician. Can I summarize something like that before we move on to the next part?
Yes,
Yeah, Benjamin.
For the moment, yes.
At present, yes. And Professor Miller, what do you think about this? Can we summarize like this?
Yeah, yes, I think it. We have to sort of think about in the context of who's seeing them. So I think in the context of an orthopedic surgeon, the current diagnosis continues to fit well with what we've been doing. I think if you're a geneticist, then their goal will be to thin down and make sure that nobody has a diagnosis of cerebral palsy because they'll find genetic diagnosis for everybody. And similarly, neurologists, are always bent on finding minor things that can explain the disability. And at least in our area, some of the neurologists are very reticent to give the diagnosis unless they absolutely can't find any other explanation. So I think it depends a bit on your specialty. That is my sense.
Okay, so after the clinical practice, let's move on to the other area, and that's research, and particularly for the people who are making the policies. So again, the question to Freeman, how does this new description is going to affect research part?
Yes, I'm not sure. I think it has from a research perspective, if we are looking at the impact of condition on the lives of people, then I think this broader overview, especially for adults, will be very helpful to allow us to incorporate the concept of how adults' lives are being impacted, how the resources available to them are being impacted. And I think from that perspective, and also the focus on inclusion and the societal impact even for children, I think actually acknowledging that in the description will be very helpful. Again, I think if the research is focused on more physical attributes, say how a child walks, and our focus on trying to, from an orthopedic perspective, making an improvement on gait, it probably won't have much impact. But I do think, as Dr. Joseph mentioned, impact on the perception of what the future can do. Especially, I'd like to highlight that last sentence in the familiar language description. I think it could be quite problematic in giving patients unrealistic hope, both because we are not going to be able to cure, say, a patient who's had a stroke and is left with a disability. There's a limited amount we can do, and how people interpret the comments of a meaningful life is so variable that I think it's a bit worrisome.
Okay, so the research was one part, and now the second part, which is very important, is whenever we are doing a clinical trial, we have an exclusion criteria and inclusion criteria, both for the registries and for the clinical trials. So, Dr. Joseph, do you think that this new description will help us from that point of view?
I don't think at the moment it will. I think it has to evolve further. You need to be able to classify, for example, if it's genetic group, type, and see if their behavior is different from another group. If you look at your MRI and you find that mainly what you're seeing is parental aplasia, in another group it's mainly corpus callosum, some is missing or something like that. And depending on that, if there's a different pattern of progression or different response to our treatment, then we might come up with some answers. But then again, that is clinical. It is strictly clinical.
Okay, so like if we summarize this, it's definitely a step forward. But if we look at our practice or our research, then probably this description is not going to change much. That is what I understand from the interaction which we have. Martin, what do you think about this? You must have expected some major change via this. So what do you think?
I agree. It depends on perspective. I think there's been a major change in the sense that we've moved from, not we as the group of authors, but the process involved, has moved from discussion of a disorder to discussion of a way of life or a way of being. So we're no longer talking about a disembodied imaginary entity, cerebral palsy. We're talking about how a person lives their life and how they experience it. And that shift won't change how we deal with them or how we manage them, but it might change how we think about them and might help us to move forward.
Okay, we have few minutes left, and either Professor Miller or Professor Joseph would like to say something additional to that. Yeah, please.
The one comment that I would make is there's a lot of emphasis on developing registries. And that's the one area where potentially how people interpret the definition will impact on who gets included in registries. So again, this is the reason why I would like to see in the definition a more clarified, being a bit more clear that this is a phenotypic description and that etiology ideally should be secondary. So you should have a phenotypic description and an etiologic description, and the two should go together. And I think that's part of, from the clinical perspective, that's missing in this definition. And that will have especially implications for how registries use this definition.
Yes, and Professor Joseph.
I agree entirely with Freeman on this. I would think that that's the way to go. And to Martin, I think the work that's been done is outstanding, and I hope that it will help us in the future. I'm not going to be around to see that, but anyway, I hope something more will come out.
Thank you.
There is probably one question. Yes, the question is from the Isha. Sir, could you please shed some more light on the upper age limit though currently it has been excluded from the description. Yeah, Martin, can you answer this question?
I can try. I think part of the concern is that there appear to be, looking in on pediatric neurology from the outside, there seem to be perceptions that there is almost an external, valid, concrete diagnosis that people reach, but instead we have lots of different opinions, and we have people with different timings for the upper age limit. There doesn't seem to be a consensus within the clinical community as to this. So it wasn't included in the description because it was likely that we get even less agreement than we do from excluding it.
Thank you. And then there is one more question from Dr. Jonathan Reddy. May sound simple, but when I often tell patients that cerebral palsy is a non-progressive condition, yet they see worsening deformities or increasing functional limitation over time, how do you suggest that we reconcile this medically accurate? Because this is a confusing language. So yes, again, I fully agree with him that this is really confusing to us also, or to parents also, or the family members. So Martin, how are you going to take this point further?
It is confusing, and I think possibly the key is to phrasing it as a neurodevelopmental condition. So if you have initial non-progressive lesion or problem, that's going to affect subsequent development. And it's when you put the Benjamin, Professor Joseph made the point really well earlier, it's not a progression of the underlying neurological problem. But if you add growth and altered growth pattern in, you don't need a change in the underlying neurological problem to have a change in musculoskeletal growth and function. And that may be the best. It's a difficult idea to approach, but maybe seeing cerebral palsy primarily as a neurodevelopmental process may be easier than seeing it as a static diagnosis.
No, like I say, my concern is that there is a confusion in the thing that it's a non-progressive disorders, but we see progress in the deformity by using a complicated term like a neurodevelopmental, which is a bit difficult for me to understand also. So how this is going to help us?
Well, we took out the term non-progressive.
But
in the description.
by adding the
So we were in agreement.
neurodevelopmental, by adding the neurodevelopmental, what, because I don't know anything about that. So how it's going to help people?
Neurodevelopmental would imply a process of growth, development, and change. So then that it's the difference between having a neurological lesion in an adult and a child. That there are, if you have a non-progressive neurological lesion that affects the process of growth, then that may well lead to alterations in muscle bone development and musculoskeletal function. I appreciate it, and thank you for highlighting it, because this is exactly where we need to look and see how a phrase that we argued a lot over all the different terms in it, but generally came to an agreement. But having an agreement within a relatively small group is not same as having an agreement within the wider clinical concern. So that's why this is still very much an evolving process. We haven't finished anything.
Okay, the last point on the question is, like, I would like to take opinion of both Professor Miller and Professor Joseph. If you have to reframe this point, how will you do that? Yeah, Freeman. You are mute. Freeman, you are mute.
Are you asking about reframing the concern about progression?
Yes, exactly.
Yes, versus. Yes, it is a difficult condition. And the way that I present this to families is that the primary underlying the primary underlying condition, the primary etiology that caused the condition is non-progressive, but that growth and development will bring forward different changes from normal growth and development.
Yeah, and Professor Joseph, you are very expert of making the thing simple. So how would you help in this complicated thing?
I just would explain that the neurodevelopment disorder, or the damage that has happened to the brain, that is undoubtedly static. It's only the consequences that are maybe progressive. And that's solely because it's a pediatric disorder to begin with. The progression is much less evident in the skeletally mature, in the adult, though some change might take place. So if you understand that, I don't think it's too difficult to try to explain to patients about that.
No, for us it's easy to understand, but explaining this to the family is the challenge.
Yeah, I mean, if you can make it clear that, take the example of the disease itself, say that it's not going to get any worse, but you might see changes like deformities become more pronounced because the abnormality of tone is there, which is not going to go away. And the lack of balance is there, which is not going to go away. So these issues are not going to change. But what is going to change is probably largely the musculoskeletal effects. And that's why I chose something as dramatic as a crouch.
Yes, yeah, thank you. Over to you, Dr. Mallikarjun. Sir, you need to unmute yourself.
Now I'm audible, sir.
Yes, please.
I thank Professor Martin Gough and Professor Benjamin Joseph and Professor Miller for sharing their valuable insights and expertise on updated description of cerebral palsy. And really, we are honored to have you with us on this webinar. And we are grateful to you and looking forward to for many more such valuable dissemination of your expertise at our ISU webinar.